Stevenson.
Good morning, my lady. The first witness today is Dr. Salman Wakar.
If you repeat after me. I swear by Allah that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Good morning. Please can you say your full name?
It's Salman Wakar.
Dr. Wakar, thank you for attending today to assist the inquiry. A few preliminary matters. Can I just ask you to speak up, keep your voice nice and loud and directed towards the microphones, and speak slowly, please. You have made a witness statement on behalf of the Federation of Ethnic Minority Healthcare Organisations, dated the 6th of June 2024, INQ 000485278. Can you confirm that you've read that statement recently and are its contents true?
They are.
I just want to touch briefly on some background matters. You are a practicing GP, is that right?
That's right.
You hold a number of senior training roles and fellowships, and you're one of the founder members of FEMHO, as I'm going to call the organisation.
Correct.
FEMHO, briefly touching on the nature of the organisation, it is a voluntary multidisciplinary consortium. So it comprises of over 55,000 individual members belonging to 45 organisations and networks, and brings together organisations on behalf of Black, Asian and minority ethnic health and social care workers at all levels within health and social care. Is that correct?
That's correct.
Can you just set out for us what the aims of FEMHO are?
So we are healthcare workers who have been working in our day jobs in the system, but also part of the communities that we hail from. So we recognise many of the issues that affect us. So we are trying to address some of those structural issues that impact us and to try to offer solutions in a workable way to the system. So we engage with health policy individuals and organisations, as well as back to our communities as well.
Thank you.
Dr. Wakar, I'm terribly sorry, probably my age, you'll be able to tell me as a GP. If you could speak up, I'll be really
sorry.
If we can begin with one of the most fundamental of areas of concern that you raise within your statement, which is the issue of historic mistrust amongst ethnic minority communities. Your statement explains how those historic experiences have fed into mistrust of the healthcare system and of vaccines, as we're looking at obviously in this module in particular. Can you explain, please, how some of those past experiences contribute to lack of confidence in vaccination programmes?
Certainly. So I think it's important to recognise, as the inquiry has rightly heard in the past, that these are not new issues. These are historic, but they're not historic for us because they're lived realities as well. And we also have the skin in the game as well, if I may put it that way, in that we know that our relatives and ourselves experience disproportionate outcomes in many other areas. We know, for example, that if you're a black woman, you're 3 to 4 times more likely to die during childbirth. So if you're carrying that into the pandemic, you are obviously going to be looking at this and thinking, are the same things going to be happening to our communities as well? And I would say that there may be, and this isn't an academic point, but I think there may be a difference between mistrust and distrust as well. I think you may have misgivings about a system, but if you have more than misgivings, if you think the system is actively harming you, by evidence, the evidence for that you can give through your own lived experience and through the fact that in the past, when it comes to vaccination, we have several examples, such as the Tuskegee trial in America, such as in this country, the UK, we had radioactive chapatis given to ladies in the 60s without their consent. These things filter through the generations. And so when we are exposed to the COVID-19 inquiry, as we set out in the evidence as well, I think those things are very much at the tip of people's thoughts, and they drive the behaviours that we saw in many of these communities.
Thank you. Can I just ask you to slow down in your answers so that the stenographers can record your evidence in full? You cite as a factor in eroding trust the use or misuse of personal data of ethnic minority people as being an experience that's been reported to you. How does that feature in the issues that you've just talked about?
So you can't fix what you can't see. And we saw during the pandemic that poor data around ethnicity and many other factors drove some of the awareness and some of the responses that the system gave to the affected communities. If you don't trust the fact that you record your ethnicity on a system or your religion or any other characteristic of yours in your GP record, in your hospital records, in any other official records that exist, because of what you have not only seen yourself, but you have heard other people telling you, or you just have a view that this is what happens to your record, those data won't be visible in the system. So we were going into this somewhat blinded in terms of not knowing the full extent of the issues that we had.
So I'm just going to pause you there because we're going to come on to the adequacy of data recording of ethnic minority group identifying information. But in terms of issues of trust and confidence, was it the case, as you set out in your statement, that in the past there have been issues such as use of the Home Office and communication between the NHS and the Home Office, which has affected the trust of some ethnic minority community members in healthcare services and vaccination programmes?
So yes, that's correct. Yeah.
You also refer to the rapid development of vaccines as many of your members saw it as a factor affecting trust and confidence in the COVID vaccines. Can you explain how the speed of development fed into issues of trust?
On the one hand, it was phenomenal that we managed to do that as a nation and as humanity, that we were able to put those vaccines to market. But when you're dealing with a community which has got these issues around where are you going with this? What is the ultimate goal of this? When you have other people out there that are taking advantage of that, which I know we'll talk about in a moment around communications, it just means that if that's not appropriately communicated, that just enhances that divide that people have in terms of understanding what those, why has it come about so quickly, and have we made some shortcuts here, and could that potentially harm our communities more? Given the fact that what we know about the historic issues that affect them.
So really it's about communities being satisfied that all the proper legal safety procedures have been followed and that this has followed a thorough course of trials and regulatory approval.
Correct, yes.
That brings us on to then the issue of clinical trials and diversity in trials. It's a concern that you highlight within your statement that there has been a historic issue of underrepresentation in clinical trials. Can you expand on why that was a significant issue for the communities that you speak for in terms of COVID vaccines?
So when you are communicating to people about any sort of therapy, you want to reassure them that this is the right therapy for them and any risks are outweighed by the benefits that they will have. And often people will ask questions around safety, as you've alluded to. And people want to know, is this right for me and people like me, given all of these things that we just discussed about around the inequalities that they experience? If we're not able to say to them that these medicines, these therapies have been tested upon people like you, and that isn't just purely a genetic thing, it's also about people who are in the similar lifestyle situation as them, for example, their social situations, economic situations, how they interact with one another. We know, for example, in COVID, there is a serious risk of transmission. So if you are from a community which socializes a lot more or socializes in certain ways, then the way that those data will present themselves in real life will be potentially quite different from what they are in other communities. And we know that ethnic minority communities have got inequalities, as I mentioned earlier. And these social determinants of health don't necessarily come forth in the way the data are presented. And so when we put that to communities, it's important that we're able to say that these medicines, these vaccines, have been tested on people like yourself. And that's why you can have more confidence in the data that they show around the safety and effectiveness.
So would it be fair to say it's not just about ensuring that the trials include a representative group from society, but also that healthcare professionals who are giving people information about the vaccines are well informed enough to be able to tell them that people, to borrow your words, who are like them have been included in trials?
Correct.
I want to move on now, please, to the effectiveness of the post-marketing surveillance systems for the vaccine. So starting with the yellow card system, how would you describe the level of awareness and understanding of the system amongst the communities that you represent?
Not particularly good. I would go so far to say that I don't think many people are aware of the yellow card scheme even now. And this is just amongst, I think, minority health workers or patients. I think amongst the general healthcare workforce, the yellow card scheme is perhaps not particularly well understood. As I've outlined in my statement, and just to briefly summarise, it's currently still only available in English. If you go today on the MHRA website, it asks you to use Google Translate to translate the yellow card scheme if you wish to report it online. And there are many other factors that I've mentioned again in my statement around the fact that the way it's distributed is still very much you have to go out your way to report it rather than asking communities to report about it. And I think it circles back into this issue of trust. If people are concerned about the side effects and the safety of the vaccines, as we've set out, there should be mechanisms in place that allow them to express those in confidence, and then to have the transparency around what are they actually seeing, insofar as how it's affecting their community, so that they will have more confidence in taking the vaccine and other therapies in the future.
Could we look then at having identified the problems that you have with the yellow card system, what are some improvements that you might suggest to make it more inclusive?
So, as I mentioned, I think the translation element is certainly one that warrants further exploration. I'd like to come on later about some of the limitations of translation later in my evidence, if I may. But I think it is important for communities to know that this is available to them. But the way that the yellow card is available, for example, if you go to your pharmacy and you wanted to report something to your community pharmacists, are there mechanisms in place there where those trust relationships do exist, particularly in communities where community pharmacies are particularly well anchored into those localities, for people to be able to express their concerns about the medicines that they're taking. But also the card itself doesn't collect demographic data. It doesn't collect ethnicity. I just looked at it the other day. It still doesn't collect data around ethnicity, and also occupation, speaking as a healthcare worker as well, if there was any occupational impact of that. So those are just some examples of how the yellow card could be improved.
You've touched already on communication and accessibility of communications, and that's the next topic I would like to come to. The words that you use in your statement are an inexcusable paucity of accessible communications when it comes to information about the vaccines and how to access them. Could you expand on that, please? What were the difficulties encountered?
I think that this for me, I think it brings everything together. So when you have got the situation where we are in, where there are existing historic inequalities, you've got the issue around distrust and mistrust in the system. You've got systems that may not necessarily be set up well to pick up some of these signals for all the issues that we've identified. I think it then is incumbent upon us to try and identify effective mechanisms to proactively address those. And so I think because the visibility wasn't there, we weren't able to see effective communications come forth. And I would say that, if I may, my lady, use a phrase, there's this idea that if someone says the moon is made of cheese, for example, you have to exert an order of magnitude greater of effort to try and debunk that, because it's very easy to come up with something that is completely nonsensical. So this BS principle, if I may call it that, is something that we saw a lot of. And I say that because for our communities to actually exert that extra effort was an order even greater than what someone else would have to do, because we're dealing with so much more issues in our communities to tackle.
Are you referring here to misinformation or misleading or false information about the vaccines that might take hold, and the difficulties in counterbalancing that? Is that what you're referring to?
Yes, but also the fact that much of the misinformation had in it kernels of truth. And how do you disentangle the truth from the misinformation is what became a real challenge for us, given the fact that we didn't necessarily have the resources to be able to do that, because, as we set out in our statement, that it became incumbent upon us to go out into communities and to do that work on behalf of Public Health England and other agencies.
What resources, sorry to interrupt, Susan, what resources would have helped you? I mean, it's really difficult once misinformation gets out there on social media. So how could anybody have assisted you in stopping the spread of misinformation and correcting the position?
At the time, one of the social media companies, Facebook, actually gave 2 of our member organisations about $500,000 in ad credit to go out there and continue doing the good work that they were doing. We didn't get that in kind from our existing government agencies, for example. To be invited to sit on tables, to have those conversations so that we are able to take that information back to our communities in ways that are meaningful. So, for example, if a community, an ethnic minority community, assembles in places of worship or does certain cultural practices, they want to know specific data around what about our community in the contexts that we're in. It wasn't easy to have those conversations. So I think being invited to those platforms and being given having that equity of access to information is important, and then being resourced to do that. And we set this out later, that all of us in FEMHO, the 45 networks that are in our organisation, are all doing this in our spare time, and we're all working as clinicians as well. I think I would say this, but I would say that there is great value in having someone who is a clinician, who's able to understand the clinical issues, but also from the communities that are affected, to act as that boundary spanner and to bridge some of those issues around trust and mistrust, but also present the good work that we're doing as well. And I think there was an opportunity there that wasn't taken up.
So if we summarise those practical changes that might help, the properly resourced ability to go out into communities and disseminate information, the social media or online campaigns that you have described, and you also referred earlier to translation or translation services, and you said it's not just about translating. From a practical point of view, what did you mean by that, and what could change to improve things?
Translation is very important. It is very helpful for people to feel more confident and feel more aware that they are having an equitable offering of health resources made to them. But we often made this point during the pandemic that the messenger was sometimes more important than the message, by which we mean that it was wonderful having Professor Chris Whitty and the other chief medical officers on our television telling us about what we must do. It was wonderful to see the graphs and those data being set out around what was going on in our communities, but these were not the most effective messengers for the communities of interest that we're talking about. And so you didn't necessarily even need to translate any of that. You just needed to have the right person in the right room talking to those people. And then I think it just goes back to that point that I made around you had those people available. You had ethnic minority health workers and other leaders within ethnic minority communities at the ready, doing lots of great work, I should add, as I mentioned in our evidence. Lots of work was done and still is being done to this day, but it's just not seeing the light of day and being resourced equitably to do so.
There was, of course, a government-run scheme, the Community Champion Scheme, and you speak in your statement about how effective that was. Could you tell us the views of the organisations you represent about that?
Our organisation members did not have visibility of that, unfortunately.
When you say they didn't have visibility, what do you mean by that?
we didn't know that that was available. I think any members that did, it wasn't clear how they might access it because I think it was distributed through local councils, not centrally through local government, and via health professional organisations working within the health sector, not necessarily within the local government space. So I think the other element is also because we are voluntary organisations, anyone who works in the VCSC sector knows is that you need to have a certain degree of organisational maturity to be able to access some of that funding. And so I think that made that more difficult for us, for those individuals who were aware of it, to be able to access it. But certainly from the majority of our 45 members, if I may say all of them, none of them accessed that funding.
Is there anything else that you would like to add about the issue of engagement with government? And I'm thinking in particular of something you touched on earlier about including people in as stakeholders in the committees or parts of government that are making decisions. Can you tell us about whether that's important and how you would like to see that change?
Yes, I think a recognition that, and we've heard through the inquiry already, that these systemic issues do exist, I think is incredibly critical to allow those other doors to open. We have found it a concerning and consistent issue that the issue of racism is one that is just not discussed. We seem to skirt around it, around the issue of should people have vitamin D or not, as we heard in earlier modules. Should people be prioritised or not for the vaccination based on other issues other than race? Should people get access to PPE because they wear beards or not? But the issue of race seems to be one that we're still quite squeamish about to discuss. And I think it's a very important issue for us to discuss because, as we have heard, it is one that consistently comes up. And the lack of our ability to be at these the tables to make some of these decisions means that we're not able to bring all of this information that I'm able to tell you now effectively into those spaces. And again, earlier we've heard about, I think it was the previous module where my colleague, Professor Burma, talked about issues around some of the terminology around communities being hard to reach and consistently using terms such as vaccine hesitancy when describing what for these communities was actually a very logical decision. I mean, we should be hesitant because of what we have experienced. It's actually an issue of confidence. I think that, that language and the ability to be effective all stems from the fact that we haven't necessarily understood that there are issues of racial inequalities and racism that affect these communities.
And is your concern also that if government are using the language of hard to reach, for example, that might lead to alienation amongst communities who are hearing that language and feed into the cycle of mistrust?
Certainly, and I would add to not only the communities, but the policymakers and the individuals that are involved in setting these policies. It externalizes the problem, that it's not us that we need to do more, it's those communities that they need to do more.
The final topic I would like to ask you about, vaccination as a condition of deployment. Why was this such a key area of concern for those you represent, please?
For all the issues that we've already discussed, if you are experiencing bullying, harassment, ostracization anyway at your place of work just because of the colour of your skin, and on top of that you've experienced in the pandemic already an excess death amongst your co-workers, I think something like 63% of people who died during COVID who are health workers were from BAME backgrounds. When you've experienced issues around accessing PPE, when you've experienced issues around every time you raise your voice to talk about can we have more inclusive things for our communities, you're shut down. And then you're told that you've decided not to take the vaccine on the basis of the fact that you haven't got the confidence around the issues to do with the trials and issues to do with the side effects and so on, that you're told you're going to lose your job. In an environment where it wasn't necessarily discussed as an issue around role and task rotation, it was a case of you either have your job or you don't. I think it wasn't surprising that we had so many people deciding that they weren't going to continue their work if they weren't vaccinated, had they made the choice not to be vaccinated. And I think in terms of a solution for that, because we want to try to avoid this happening in the future, I think if we do all of what we've already discussed, we should hopefully find ourselves in a situation as we did with COVID that we didn't need to use vaccines as a condition of deployment because enough people had confidence to get vaccinated. But I hope we're able to do that sooner using some of the things that we have already discussed so that more ethnic minority health workers and indeed other members of the public and other healthcare workers will feel confident and they won't need to have it made a condition for the deployment.
That concludes the questions that I have for you. Does my lady have any questions?
No, I don't. I'm extremely grateful to Dr. Farrell. Please continue your good work, both as a GP, trainer, and obviously acting for FemHome. Really grateful to you for what you do.
Thank you.
My lady, the next witness will be Yvonne McNamara.
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you for coming to help us, Ms. Melvin.
Thank you for inviting me.
Please can you say your full name?
Yvonne McNamara.
A few preliminary matters. Could I just ask you, as you may already have heard, to keep your voice up and into the microphone nice and loud and to speak slowly. You have made a witness statement on behalf of the Traveller Movement dated the 8th of January 2025, INQ 000474770. Can you confirm that you've had the opportunity to read that statement recently and that its contents are true?
Yes, I did, and the contents are true.
Thank you. I just want to go briefly to the background of your organisation. The Traveller Movement is a charity which advocates on behalf of Gypsy, Roma and Traveller people, and you are its Chief Executive Officer, is that right?
That's correct.
Traveller Movement you describe as an advocacy movement, particularly important in a society where the voices of Gypsy, Roma and Traveller people often go unheard. And you're the largest organisation in the UK which represents the interests of those three communities. Is all of that correct?
Yes, that's all correct.
I'm going to, if I may, adopt the language that you use in your statement, the shorthand of GRT, to describe those communities.
That's absolutely fine. The only thing I would emphasise is that we are talking about three separate communities. So we're talking about Irish Travellers, Romany Gypsy and Roma. And I think it's important that we kind of acknowledge that. But it's fine
Yes.
to use the shorthand.
And I assume that you're pointing that out because all of those communities have different cultures, different needs.
Yes, yeah.
Thank you.
Similar but different.
We will go on, I think, to talk about the fact that there is poor government data on the number of GRT people in the UK. But as an estimate, could you give us an idea of the size of the communities that you advocate on behalf of?
It's a difficult one, a very, very difficult one. I mean, we have the data from the census, the ONS, and there's a very crude Gypsy caravan count, which identifies 260 currently caravan sites in the UK. That's a very crude way of doing it. But we estimate that we're probably looking at over 500,000 people.
You summarise within your statement that the health position of the communities you advocate for in this way, that Gypsies and Travellers experience some of the poorest health outcomes in the UK, including the lowest life expectancy of any group, which of course makes communities more vulnerable to COVID-19. It's also important, excuse me, to acknowledge that the inquiry's received some expert reports which will be considered, but give an indication that, at least in a study in Scotland towards the end of 2022, it was estimated that just 55% of Gypsy and Traveller people had not had their first dose of the COVID vaccine. So is that the context in which you are giving the evidence that you're giving today? Thank you. I'll move first then to asking you about the barriers in access to information about COVID-19 vaccinations. The first that you speak about in your statement is that rates of literacy have historically been low in GRC communities. Can you explain how that affected accessibility when it came to the COVID-19 vaccinations and information about them?
Well, many individuals, clearly faced many barriers. One, which is the low literacy levels, digital exclusion, internet access, use of pay-as-you-go phones. In relation to the literacy, a lot of that would very much be about, historically you have had a lot of people not being able to from those communities, being able to access appropriate education services and excluded from school. And this is well documented. So that has been going on for a number of years. And in relation to any information that would be shared by the health authorities during the COVID pandemic, people aren't going to be able to receive that information or avail of that information if they have poor literacy. I mean, I think the thing on all of this in terms of a lot of the barriers and the exclusion, I have three kind of key areas that I would suggest are about the exclusion, and that's the relationship around trust, invisibility, and communication. And to expand on that, without visibility and inclusion in official statistics, these communities don't exist. So let me expand further on that. The NHS data model and the NHS data dictionary do not include these communities. They don't include them. And without this inclusion, people are going to be overlooked in local and national health strategies and delivery.
Can I just pause you there, because I assure you we're going to come to those issues of data and of the NHS dictionary. I just want to make sure that before we move on to those issues, we're clear on the barriers that were faced. So we've talked about the combination of literacy levels and digital exclusion, meaning that if you're getting a vaccine invitation by letter or you're being asked to look at government alerts that might be in writing on the internet, that's going to be a barrier to access.
You're not even getting that. You're not even getting that information because you're not on a system. You're invisible. For example, the text message that would have been sent out to vulnerable communities around shielding, most gypsies and travellers wouldn't have got that because they're not in the system. So it goes further than the literacy. Much further.
Yes, and I know that GP registration and data is key in that, and we will get there. But before we get there, can we just cover the topic of the availability of health services for people who do not live in a permanent address, and that some of the issues that may come around moving house or moving site. Would I be right in summarising your concerns like this, that if people are moving address frequently, then they are less likely to have a GP who is local to them, who is a regular GP, who they are registered with, and therefore they may not have ready access to their health records. And those health records may be very important in helping them and healthcare professionals to understand whether they fall into a vulnerable group for prioritisation.
Yeah.
Is it right that in the past, there have been mobile health services for
Yes.
these communities.
Under the, I think it was probably we're looking around 2008, under the Pace Setters programme, there would have been a lot more development and engagement around mobile services, and there was also the development, which I specifically, the Traveller Movement, along with other organisations, worked on, the handheld records. Our understanding is they no longer exist. A lot of that kind of stuff was stripped away. So there are few and far between. I can't identify any mobile services at the moment, and I don't know anybody that currently has the handheld records. So that is non-existent at the moment.
So two issues there then, really. The first is that the mobile health services allowed people to have someone they could go to with health concerns or issues who they could build a relationship of trust and confidence with.
Exactly.
And that might have been very useful when vaccinations were rolled out, because if they had questions about vaccinations, then that would have been a health professional who they knew and trusted.
Absolutely. Like, the mobile health services would have been a critical resource, absolutely a critical resource for communities, because they would have been able to explain about the virus, what the virus entails. They would have been able to kind of, some of the fears and anxieties people had about what was happening, they would have been able to answer that. And they would, by having those regular mobile services, people would have had the handheld records.
So that second issue of handheld records is about people owning their own health information, so that they can understand, for example, if they might fall into...
the records, and if they're moving to a different location, it is easier in terms of GP registration to be able to go into a GP service with the handheld record. But, you know, as I say, none of that is in existence now.
Well, that perhaps leads us on then to the issue of GP registration, obviously interlinked, as you have already explained. You explained that many members of the GRC community, whether they move frequently or not, are not registered to a GP surgery, which can result in poorer health outcomes generally, but also contributed to issues with booking vaccinations. Would it be right to say that put simply, because the invitations to vaccinate were linked to GP registration, if you're excluded from that system, as you put it, you're just not getting the information?
Yeah, absolutely. You're excluded from that system, but that system hasn't got you on the system, so it doesn't know. It doesn't know that you exist. You're totally invisible.
The interlinked issues that we've just talked about to do with visibility on the healthcare system and having access to mobile health units, what more do you think could be done or improved in the future to address those difficulties?
Well, I think the reinstatement of the mobile health service is absolutely crucial. By developing the mobile health service, that is an outreach. You're building the relationship with local communities. People, you can do, as part of a program like that, you can also develop your education programs around that, because people get to know that health worker, they get to know when the mobile service is coming, they can ask the questions they need, there would be regular contact, so they're more familiar with the need for vaccines. They're also kind of getting, building up their health and well-being in so many different ways, because they're getting proper health so they're getting access to dental care, they're getting access to health and well-being in so many other different ways. They're becoming aware, so that when something like a pandemic happens, they're much more familiar with the health system and who people are. So yeah, absolutely vital. We need more investment in the health service, the mobile services, and developing the handheld records.
I'll move now to an issue that you've already mentioned, which it's clear from your statement is a very key concern for your group, and that is the representation of your communities in the NHS data dictionary. Can you tell us about that concern, please?
Yeah, well, this is a drum we've been banging for many years, you know, and the NHS data dictionary, NHS data model is really, really important. If you're not there, you can't commission services. You can't be part of local planning. So, you know, it's very much about, and particularly with what has happened with the pandemic, it has failed miserably, these communities, simply because the trust wasn't there, the visibility wasn't there, and the communication wasn't there. So you can't build the ark when the flood is happening. So if you want to develop those local commissioning services and you are serious about addressing health inequality for a community, you have to capture, you have to know who's in your local community, you have to know your local demographics. And in most of the local authorities, I would say there is no local authority in this country that doesn't have a local gypsy and traveller community. And we have to remember, we're not talking about a new community. We're talking about a community that have been here for the last 500-600 years, but are just not being captured in any of the data. So it is absolutely vital moving forward that the NHS start to address this issue and include these communities, because this will happen time and time again, and we will never, separate to the pandemic, we will never address any of the health inequalities for these communities if we don't start to recognise and acknowledge that they're here and they're part of the local community.
So there is an importance in making sure that when people are registered or engaged with healthcare services, their membership of a GRT group is properly reflected in their records. And that is important for commissioning services, as you've explained.
Vital.
But also, is it important so that when local or central government are looking at uptake of vaccinations, who is taking the vaccinations from which groups, where are they taking it, that you need that data to be able to follow trends.
It's just so important, and because the community is so excluded. So, you know, I will give you an example of why this is really important and why the mobile services, you know, I'm thinking of, and this happened on numerous sites, but I'm thinking of one particular site where there was an incredible amount of vulnerable people on that particular site that should have been shielding. Now, within that site, as indeed a lot of sites across the country, many people will use generators for their electricity and their refrigeration of medicines. They will also use things like pay-as-you-go mobile phones. Because they're not captured in local data or commissioning, no service, no contact was made with that site. When people from that particular site tried to get the information and the access they needed, but equally tried to get petrol or diesel for their generators or try to renew a prescription or top up their phone, it wasn't a local mobile service or a health service that was sent to that site. It was the police to prevent them from moving and coming off the site because of the restrictions. So those people were left they were completely abandoned and isolated. Now, had they been captured in local data, had there been a mobile service in place, had that trust been in place, we may not have had a lot of the issues that arose. And that's one particular site right across the country for these communities. And I can absolutely guarantee you that uptake of the vaccine would have been much better. We would see some statistics on it, like, you know, one of the things that has actually happened, and I'm delighted to be here in this inquiry, but, you know, yesterday a graph was produced by lead counsel for the inquiry. And on that graph, and rightly so, numerous communities were detailed about their vaccine uptake. Gypsies and travellers were again excluded, and that's in the inquiry's own data. We weren't on that graph yesterday. But yet, if we go to Scotland and we look at what has happened in Scotland, which has a significant but a much smaller Gypsy Roma traveller community and doesn't have the same resources and certainly wouldn't have the sector in terms of the not-for-profit sector in Scotland, they had captured the data. So that's what happens when you continuously exclude and not include people.
And what is able to be included in the graph that you're talking about, shown by the inquiry, reflects the data that was available to the experts who have assisted
Scotland,
the inquiry.
And not here.
And so it is what you're saying, that it isn't enough to include Gypsy, Roma and traveller people in the other category when it comes to ethnic minority groups, because Gypsy, Roma and traveller communities have specific needs and circumstances that mean that they ought to be, as a group, specifically reflected in government data.
They have their own. They are a protected group. They should have been captured within all that data separately.
I'm going to move on now to the issue of historic mistrust and reasons for lack of confidence in COVID-19 vaccinations. You speak in your statement about some overarching reasons for the mistrust of public health advice, which in turn affected the level of trust that some people had in vaccines. Are you able to talk to us about that, please?
Yeah, I mean, you know, as I said earlier, we're not talking about a community that has just arrived on these shores. We're talking about Romani Gypsies in particular, who have been on record here for the last 500 years and have been continuously excluded from any kind of provision or service. So mistrust is going to develop. They're very much persecuted communities, so mistrust is going to kind of develop. And over that time, because there's been no proper outreach programs, no political will, no gestures of trying to include people in the development of these services, people are incredibly suspicious when something like COVID-19 happens and they're told that they have to get a vaccine, because they haven't had the inclusion, they haven't had the education. So one of the concerns from the community around the vaccine would have been infertility. Another one would have been high rates of autism. Now, a lot of work for different communities has been done around educating people around these areas, but nothing has actually happened or been delivered to Gypsy Roma traveller communities or brought them in to alleviate some of those fears and anxieties. And we got to remember that Gypsy Roma traveller communities are traditionally an oral community. So the rumour mill will take hold very, very quickly. And if somebody is saying, don't participate in having this vaccine because of you'll be infertile or your child will end up with autism or whatever, that there is no literature, there is no education programs to try and counteract that information, other than what organisations like the Traveller Movement and our colleagues in the sector are trying to do. But we are a drop in the ocean, and we are very, very small.
I'm going to ask you in a moment about what practical changes can be made to help with that, but you're explaining that where there is a lack of trust and also a lack of outreach and information, into that space can move rumours and false information, as you've described.
Misinformation.
And was that a particular problem, in your view, in Gypsy Roma traveller communities?
Absolutely, yeah.
Was there a specific concern that you explained in your statement about that link between vaccines and infertility or harm to children from vaccinations? Was the community particularly vulnerable to that because of some of the disproportionately high levels of child mortality at stillbirth and miscarriage being a real concern for those communities?
A concern, absolutely. That would be a massive concern for the community. You know, they are aware of the high mortality rates, infant mortality rates of their children and miscarriage. And we as an organisation have done a lot of work specifically with maternity care. It would have been a huge issue for the community. And they would have just seen, well, we don't know enough about this vaccine, we don't know what's going on, so we're not going to kind of engage with this, because the relationship wasn't there previously with the health services.
And what changes do you think could be made to address that?
Well, I think moving forward, building trust with the community before any public health crisis. You know, and as I mentioned earlier, as the saying goes, there's no point in building the ark when the flood has happened. But trust can be fostered through sustained outreach, culturally appropriate services, and inclusion of Gypsy Roma traveller voices in policy making. I think some of the other areas in terms of building that kind of support, we've been talking for a number of years about the development of cross-government strategy, and this is not new information. The Equality and the Women and Equalities Committee, which I gave evidence to a number of years ago, have called for a cross-departmental strategy. So we need some joined-up thinking. And in that strategy, we would be looking at a national framework for better development of mobile services, a national immunisation strategy, with the voices of the community involved, proper education programmes that will include these communities. For example, in terms of communicating and how to get information out, communities are excluded from, digitally, hugely excluded digitally. They need to be included in digital strategies moving forward. So there's a number of things top-down and bottom-up that really need to happen here.
And perhaps to add to that very comprehensive list, is it important that when there are roundtables, stakeholder meetings that are run by governments, that there are representatives of the Gypsy Roma
Well, the interesting thing is there are a number of roundtable meetings, and as an organisation in the past, we have been directly commissioned to produce policy by the Department of Education. I just said earlier, we've been banging this drum for a number of years. Our first briefing paper calling for inclusion in the NHS data dictionary was 2012. We have been there. Now, as I say, a lot of that stuff has been stripped away, but there are plenty of us going to these meetings, plenty of us picking up the phone and trying to talk to, whether it's the NHS or Public Health England, and a number of these people will be in the room today, and I encourage you to come and still talk to us. But so the invitations, in one sense, are coming. It's about the implementation, the political will, and the action. That's what's not happening.
Those are all of my questions. Thank you very much for your evidence. My lady, do you have any questions?
Madam Mayor, thank you very much indeed for your help. I'm really grateful to you. You raised some important issues, and obviously I'll give them very careful consideration. Thank you very much.
Okay, thank you very much.
Thank you.
My lady, the next witness is Laura Wong, please.
solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Before we go on, can I just repeat something I said yesterday? And I know that the hearings manager is very conscious of this. People are moving around and making noise when the oath is being taken. I must insist that nobody moves whilst the oath is being taken. It's too important. But it's right, I'm not going to ask you to take it again, Ms. Wong.
Mrs. Wong, could you commence your evidence, please, by giving us your full name?
My name is Mrs. Lara Wong.
Thank you very much. Mrs. Wong, thank you for attending today and assisting the inquiry with the provision of your witness statement of the 1st of November 2024. But we'll look at a few parts of that statement in a moment. Could you please tell us something about the Clinically Vulnerable Families Group, of which you are the founder? Was it founded in the summer of 2020?
That's correct.
And was there a particular event or series of events that formed the genesis for the foundation of the group? What was about to occur in the summer of 2020 that led to the concerns formulated now in your statement on the part of your group?
So, in terms of my background, I'm a former teacher, and I was very concerned about the risks that our group was about to be exposed to in schools. They were reopening, and at that time, in August 2020, families were going to be forced into those situations with all children being told that they must be in schools. And so we were incredibly concerned as this exposed not only clinically vulnerable children, but children in clinically vulnerable households.
So because children, by and large, were not vaccinated, the great concern held by those of your members who comprise the clinically vulnerable, the clinically extremely vulnerable, for example, severely immunosuppressed, was that children would go to school, would become infected, would spread the infection around vulnerable households and more generally, of course, with terrible consequences for your members.
Yes, and not only were not children vaccinated at the time, but nobody was vaccinated.
Yes, of course, August 2020 was before the rollout of the vaccination programme. So the genesis of the group was in the concern about the spread of infection, particularly in the school setting. But the group now represents all those who are clinically vulnerable, those who are identified as high risk by living in clinically vulnerable households, and that includes clinically extremely vulnerable people and, for example, the severely immunosuppressed. Your statement sets out the very laudable aims of your group. Could we please have up INQ 000474526 and paragraph 9, which commences on page 4 in particular, please. I want to just look at some of the aims of your group in order to tie the most important of those aims, as far as this inquiry is concerned, to the scope of Module 4. Because your group does many things. It provides support to your members. It educates the wider world and those who are concerned with these issues. And it obviously assists members with their urgent needs, those people who have come up against the state, and of course, those people who particularly need medical support. But on page 6, at paragraph 9D, you've set out very helpfully a list of goals and key issues. But many of those issues and goals, of course, are properly and sensibly designed to meet the needs of your members who suffered from medical conditions and were clinically extremely vulnerable or vulnerable even before the pandemic came along. But are some of those aims, of course, directly related to the systems and processes for delivery of vaccines and eligibility for and access to therapeutics?
Well, certainly, I think it's important to consider clinically vulnerable, clinically extremely vulnerable, severely immunosuppressed as a group of clinically vulnerable people. And yes, certainly they did have those barriers early on. They're not recognised as an equality group. They are kind of new, and our needs were certainly not met prior to the pandemic. We would very much agree with that. And needs such as clean indoor air was never considered before. Access to schools, workplaces, job losses are serious issues that our members have faced as a consequence of the pandemic. You know, that they would have viewed themselves as healthy enough prior to the pandemic, and then those risks seriously impacted on them. So I wouldn't say that it was the same.
Because of COVID-19?
Because of, yes, it was a new...
So the heart of the concern is that the pre-existing needs of your group members were exacerbated, made worse by the danger posed by COVID-19 itself.
Very much so.
So
yes.
what you're most concerned about is improving the systems and processes for delivery of vaccines and access to therapeutics in response to the heightened risk posed by COVID and other pathogenic diseases.
Very much so. And I mean, we've failed to recognise those needs. Access to vaccines, there were issues there, and I know we'll go into that. But there will be issues in the future for us as well. Access to antivirals has always been hugely problematic. It is still problematic for us to this day. Access to prophylactics, we've never had a prophylactics available to us on the NHS. So, yes, we have been let down.
But obviously, you appreciate that this inquiry can't investigate the far wider, more general topic of access to or eligibility for therapeutics, or, of course, for vaccines generally. You can only focus on the systems for their production and delivery.
Yes.
All right. In paragraphs 13 and 14 on page 8 and 9, you provide some information about the definition of the members of your group and also about their extent. Give us, please, some idea of the numbers of people who, in your approach, would be said to be clinically vulnerable, and in particular, clinically extremely vulnerable. How many people are we talking about?
So, I mean, if we're talking across the country, then we believe that around 20 million people, based on the original kind of vaccine prioritization list that they had. For our group, clinically vulnerable families, we represent, we believe, around 50,000 people across various social media platforms, Twitter, Facebook, Blue Sky, and others. Our Facebook group is very active, and a lot of our support is offered there to around 2.6 thousand people on Facebook.
So around about 50,000 in your group. Do you recall that in the course of the pandemic, you may not have known then, but you'll have seen it now from the documentation disclosed to this inquiry, that the government attempted to identify the numbers of people who might be described as immunosuppressed. And they put a figure very broadly on that group as being around about 500,000 people, although it varied over time and different parts of the government took different approaches. Can you say now what the number of people broadly is who might be described as immunosuppressed?
Well, we are stakeholders in the NICE consultation around Evershed, and within that consultation process, they pointed to 1.8 million people. So we believe it's that.
So when that organisation, NICE, approached you and said, would you like to take part in our assessment process for the development and production authorisation or rollout of therapeutics, they indicated that that was their view of the number of people who might be affected by that decision.
That was the number that was published in one of their consultation documents.
Right. Thank you. In your statement, you identify a significant number of concerns and issues, and we're just going to focus on some of them. But starting with vaccination, the broad concern held by your group in relation to the events during the pandemic fall under the heading, I suppose, of lack of access to vaccination, lack of access to priority vaccination, lack of access to specific vaccines where, for one reason or another, they couldn't take one vaccine, they needed another, as well as lack of access to the booster programme. And then there's all the practical issues concerning delivery of vaccinations. So I suppose issues concerning the conditions, the crowded nature of some of the vaccination centres, the wearing of masks in centres, the lack of specific mobile delivery of vaccinations and so on. So you've got delivery and you've got availability of vaccines, boosters and specific vaccines. Is that a fair summary of the main concerns in relation to the vaccination programme?
Yes, and there was considerable confusion because you have to remember that nobody identified as clinically vulnerable or clinically extremely vulnerable or even severely immunosuppressed prior to the pandemic. So those people did not understand where they fit into this. And so it was only when very often they were contacted either with shielding letters or for the clinically vulnerable group until they were invited for vaccination by their GPs that they understood where they fit in.
So at the nub of it, there was a high level of confusion about eligibility, where, for example, clinically vulnerable people came in the scheme of prioritisation, as well as on the ground, practical difficulties with ensuring that they were being invited in for vaccination.
Certainly, and also where you're looking at people with rare diseases or complex conditions with multiple conditions sort of overlaying with each other. It was problematic because they weren't necessarily clearly prioritised into a particular group and they had to fight for their own eligibility.
And in terms of sites, so the practical delivery of vaccines, vaccination centres, GPs, pharmacies, mobile units, and across the United Kingdom, different health boards, were there very real difficulties faced by your members in terms of physically getting access to vaccines?
Hugely. We struggled. There were all sorts of barriers that we faced. We faced safety risks. Infection prevention control did not consider airborne risks. Airborne transmission of this virus is a huge problem for us, and it goes into all areas of life. But within the context of this module, of course, we're looking at vaccination centres. They were very good at wiping down seats. We weren't worried about seats being wiped down. We can wash our hands. We were concerned about the quality of air in those environments, the lack of ventilation, and the lack of proper masking. There were good examples of vaccination centres. Drive-through vaccination, people felt very safe heading out. You have to remember, this is a population who'd been shielded. They had lived very limited lives, or they had shielded themselves informally. And so this was their first kind of exposure to a particular risk. And so heading into these environments was very concerning for many of clinically vulnerable families' members. And so, yes, some GPs were great. There were examples of outdoor vaccination centres where, there were tents and things and there was great, air in the area. But, otherwise, it was overwhelming for people. And there was a postcode lottery. People did not know what to expect.
You, of course, appreciate that this inquiry cannot prescribe the precise means by which vaccines are delivered. That must be left to the specialists, the clinicians, the administrators, vaccinators, and so on. But you would say, I expect, going forward in the future, systems setting up the delivery of vaccines have to pay closer attention to the specific and slightly unusual, but no less worthy needs of the clinically vulnerable.
Yes, and we would like people to be informed of how to reduce their risks. So wearing better masks, these close-fitting masks that filter the air coming through it and massively reduce people's risks. 99% for an FFP3 mask. 95% for an FFP2 mask. People were never informed about these. When they attended vaccination centres, they were given a paper mask, and they may have been asked to remove a better mask. Same problem we saw also in healthcare.
All right. By the time the booster campaigns commenced, Mrs. Wong, obviously the system had bedded down to a very great extent, but there appeared to have been considerable difficulties with an understanding of the eligibility for boosters. What was the problem there? Why were your members so concerned about the rollout of the booster campaign?
So the booster campaign was problematic, certainly. Sorry, are we talking about the third primaries?
We are.
We are. Okay, so just to clarify. So third primary doses were only offered to a small group of the severely immunosuppressed that we have mentioned previously. It wasn't widely known that this third dose was on offer. They very often did not know that they were within this group. And whilst CVF was very good at informing our members who might be eligible for this, people found it very difficult. They attended these vaccination centres. They would have to self-advocate, bringing documents and things with them to prove that they might meet these criteria, that they had certain medications or that they had certain conditions that should qualify. But even when they did attend those vaccination centres, they found very often that the staff did not necessarily understand that even this was something that was on offer, or how to report it or record it within the NHS computer system.
Right.
So they were overwriting people's records. Sometimes they'd overwrite and then they would have the wrong date for their last dose, and then there was a knock-on to their future doses. If they didn't record it properly or record it at all, then the 6-month gap that they were expected to have for subsequent doses, there was an impact there.
Right, so there are issues there which overlap data, overlap communication, knowing what their entitlements were in terms of eligibility, and also the practical mechanics of delivering the vaccination on the ground.
Very much.
An important part of your statement, indeed much of your statement, is concerned with the issue of therapeutics. The inquiry obviously cannot become concerned in directing clinical groups, NICE, the NHS, the many bodies which are concerned in the process by which therapeutics come to be trialled, authorised and then made available. But in the context of the COVID pandemic, the very great problem faced by your members was that ultimately there was simply not sufficient access to or eligibility for as wide a range of therapeutics and antivirals as would have brought them help and support and given them a greater degree of protection. Is that the nub of it?
I would say with regard to range, it very much depended. So some treatments, for example, Paxlovid, are not suitable for many clinically vulnerable people. They are very good for older, healthier people, but there are many contraindications for that particular medication. So the need for different antiviral treatments certainly was there. I
mean, in your statement, Mrs. Wong, you make plain that there were obviously a number of therapeutics authorised and made available. Authorisation and being made available aren't the same topic, of course, but eventually there were a number of therapeutics that made it to the end of the process. And you described Paxlovid, nirmatrelvir and ritonavir. There was sotrovimab, the Zevudi therapeutic, and importantly, Evusheld, which is tixagevimab and silgavimab. We've heard some evidence, and we'll hear a great deal more evidence about the Evusheld decision. But what your members were concerned about was why, in particular, Evusheld wasn't made available and why there weren't other antivirals and therapeutics made available despite the prospect that they might be? Is that the heart of it?
Okay, so to kind of put Evusheld within sort of the context of this, Evusheld was more sort of similar to a vaccine for the group of people.
It was a prophylactic.
It was a prophylactic treatment, exactly. It was not post-infection treatment. And so it would have levelled the playing field for these people. It would have given them the freedoms that other people received through their own vaccination. And the consequence of not protecting this group was phenomenal in terms of their mental health, in terms of their social connections, in terms of their general ability to re-engage with the rest of the world. And so we have to remember that this is a group of people who, through no fault of their own and through the lack of the government's action to find or procure this treatment, left them essentially locked up without any route out. And these people still live today with these same issues, still with no opportunity and no other thing other than waiting to be infected and then having a treatment and hoping that it's effective for them.
And let's be clear about this. The reason why, of course, access to and eligibility for antivirals and therapeutics is so important is that there's a large number of people whom you represent for whom vaccines come as no remedy. They either cannot take vaccines because they would harm them, or because vaccines may not have as much or greater beneficial effect as for others. So they're more reliant on therapeutics and antivirals to help.
They are indeed, although there is a positive benefit from vaccination, and this particular group is invited twice a year for vaccinations in comparison to the other clinically vulnerable groups who are invited once a year.
All right.
So there is a benefit that's been proven. However, we have to bear in mind that, yes, for some of them, they may have no immune response, or they may have a very low immune response, and so they still remain at great risk. As they were at the start of the pandemic. They were always the greatest risk group.
Because they suffered from pre-existing conditions. Another topic which is raised in your statement is the issue of the trials, the clinical trials which were undertaken by broadly the government. The trials obviously were of themselves extremely valuable, and many of the trials led to life-changing results, dexamethasone, for example. But insofar as your members were concerned, was it the position that those who didn't qualify for antivirals, for example, might be directed to particular trials where antivirals and therapeutics might be tested on them as part of that perfectly proper and understandable trial process? And therefore your members became involved in trials which imposed on them greater burdens even to the conditions from which they already suffered. So in terms of the timing of those trials, the capacity of the trials, the treatment they received in the trials, the geographical inequalities as to where the trials were being undertaken. So many of your members had problems with engagement in the trial processes.
So it wasn't just that.
But it included that.
It certainly included that. However, I think we also have to remember there was a group of people for whom already did qualify under emergency approvals for those treatments, and yet that group, who had a 100% chance of receiving those treatments, were also being invited onto a trial where they may only have a 50% chance of receiving those treatments if they are to be accepted. So it was hugely problematic. And they may not have understood, and they may have been invited by their GP, which gave these trials legitimacy, and they may not have understood the potential consequences of those.
So there was an issue about eligibility and an issue about communication.
Very much so.
Another topic, another issue raised in your statement is that of vaccination of children. As you've already said, the proper vaccination of children and the extent of that programme was vital to your members, because, of course, vaccination of children would reduce transmission in the community, which would give a greater degree of protection to your members. Is therefore the way in which the government went about considering authorising and delivering vaccination to children something you want the inquiry to look at?
Very much so. I mean, as you can see, in terms of our submission to the inquiry, it's a considerable bulk of our statement. And that's because there were so many and varied issues that our children faced. The risks to children impacts on the clinically vulnerable household, but there are also obviously clinically vulnerable children who we very often did not hear about. There was a suggestion in the media that clinically vulnerable children did not exist to an extent, or children were not at risk. And there were children who were at risk. There were children who died, and it's really important to understand that. And for those families who are trying to protect their vulnerable children and keep them safe, it was incredibly difficult to not have access to these treatments, for the delays. If you can imagine as a child waiting for Christmas, how difficult that is. But if Christmas came, everybody else were given their freedoms, and you remained locked up. How does that feel to a child? How do you explain it to them? And as you go down the ages, the younger and younger children had to wait longer and longer.
And of course, there is the sequential impact, of course, on the rest of the household, and of course on other vulnerable people. So that's an important topic.
Yep.
And then finally, you raised the issue of disinformation and misinformation, and you set out a number of what I might call the conspiracy theories, some of the tropes, some of the myths concerning vaccination and in particular, but as therapeutics as well. Why is the issue of disinformation and misinformation and the steps which can be taken by government, in your view, to challenge it, of importance to your members?
I would say it was twofold. So there is the issue of the wider communities, those who are not clinically vulnerable, being impacted, and how that knocks on to everybody in the clinically vulnerable community. If the vaccination is undermined, then people will not take up the vaccination. But there's also the direct impact on clinically vulnerable people who are not immune to this message. They are already suffering from serious health issues, and the idea that for them, their issues would get significantly worse, it's hugely problematic. So people are nervous of taking a risk. However, I think for clinically vulnerable families members, we are a very informed group. People are looking out to learn and to be educated on these issues. And actually, I think our group was probably disproportionately not impacted by this issue.
Thank you very much. That's very fairly put. Those are all the questions I have for you.
Thank you very much indeed, Mrs. Wong. I hope that your attendance here hasn't raised any kind of risk. We do our very best to make any risk as reasonably low as possible, and I can assure you Mr. Wagner keeps us on our toes, and I'm sure you'll want to have a word with him and the rest of the team before you go. So I'll break now, and I'll give an extra 5 minutes for the break to enable Mr. Wagner and the team to talk to you. So thank you very much for your help.
Thank you so much.
11:45, please.
Repeat after me.
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Mr. Hancock, thank you for returning to help us. I do understand how difficult it must be to keep having to come back. All I can say is that the vast range of my terms of reference meant I had to break the inquiry down into modules, and that's why you're having to keep coming back, because you played such a central role. All I can add by way of consolation, if it is any, had I done it one whole report, you'd probably been in the witness box for weeks. So,
well,
thank you.
It is what it is, but
yeah.
it's also a very important inquiry.
Thank you.
Could we commence with formality of you identifying yourself, please, Mr. Hancock?
Yes, I'm Matt Hancock, and I was the Secretary of State for Health and Social Care
Thank you very much.
Until June 2021.
May I add my thanks to you for attending on what is now the 4th occasion. You are a recidivist, Mr. Hancock. You've also provided a further witness statement, extremely helpful statement, 74375, consisting of around about 70 pages. You were, of course, Paymaster General and Minister for the Cabinet Office. You were then Secretary of State for Health and Social Care from the 9th of July 18, when you took over from Jeremy Hunt MP, to the 26th of June 21. And, of course, you and your department were vitally and centrally concerned with the issues of vaccines and therapeutics. By the metric of the need to protect at a population level against the SARS-CoV-2 virus, the vaccine programme was, in the provisional view of the inquiry, no final decision has, of course, yet been made, an overwhelming success. In terms of therapeutics, the research, development, clinical trial, authorization and eligibility procedures also led to world-breaking successes. Dexamethasone is an obvious example, a repurposed drug that saved hundreds of thousands of lives. And therefore, the therapeutics program, although there were issues with it, was also in an important way a great success. So I want it to be made absolutely plain that your attendance here today is to help us address literally a handful of discrete issues which arise out of both those programs, and which you can help us prepare for the next pandemic and indicate ways in which improvements can be made, where they are capable of being made, and where also lessons have been learned as to how well the job was done, and therefore why it's necessary to embed some of those successes into the system. I know you want to pay tribute to all those who contributed to that outcome.
I do. I broadly assess with that. I wouldn't agree with your assessment. I wouldn't say the therapeutics programme was world-breaking, but I think we know what you meant. Both programmes were incredibly successful, saved an enormous amount of lives, allowed us to come out of the lockdown and the measures that were themselves damaging, and as you say, in many cases, the UK was the first country in the world to introduce measures, and so it was an enormous success. I put a very large part of that down to the fact that it was an extremely effective and cohesive team effort. And if you think of it, the vaccine programme was essentially led by four people in their elements of it, in their parts of it, and a very effective team in the department coordinating that. And from the team at Oxford, Catherine Green and Sarah Gilbert, the team doing the buying, led largely by Kate Bingham, then the team doing the validation and the regulatory affairs, led by June Rain, and then the rollout, led by Emily Lawson. An incredible group of people who worked very effectively together, and then with myself and Nadeem Zahawi and Alok Sharma and Steve Barclay at the ministerial level. So it was an extraordinary team effort.
Thank you. We'll be hearing from many of the persons whom you mentioned during the course of this module. As the pandemic broke in the United Kingdom, what was the general state in your view? You obviously had to immediately address the position of the UK's vaccine research and development capacity. Were we in a good position at that time?
We were in an excellent position with respect to research and development. not with respect to manufacture. The Oxford vaccine came out of a project which had been, for instance, deeply involved in developing a vaccine against Ebola, and the research level capabilities were extraordinary. It's important to remember when you look at it with hindsight that there was also an Imperial College vaccine, which in the end didn't come to the fore, but was a serious candidate in the early days.
That team was led by Robin Shattuck.
That's right, although GSK didn't come up with a vaccine that played a major role, they have a great capability in this space, as well as do a number of other British companies. So in the research space, we had a great depth and strength.
One of the vaccine technologies, we've heard much about it, of course, and we'll hear more about it, was the mRNA technology. That had been around for quite some time, had it not, and had already led to considerable development of vaccines, particularly in the sphere of cancer.
Well, there had been a whole series of vaccine technologies which had advanced significantly over the time. I mean, since Jenner, but especially in the decade or so before the pandemic, and really a change towards these platform technologies, which could then be adapted to a particular pathogen.
And in terms of the state of the UK's research and development sector, was much of that foundational work due to the very extensive work done in academic institutions? You've mentioned Imperial and Oxford, as well as across the research and development industry, the bio-industrial sector, all of whom had been looking for years, of course, at therapeutics and at vaccines for a variety of conditions and pathogenic diseases.
Yes, and in peacetime, if you like, before the pandemic, as in the pandemic itself, the best pharmaceutical research happens with a combination of academia, industry, and government. You need all three to make it work effectively.
In her book, Dame Kate Bingham says that notwithstanding, there was very little by way of an apparent plan to deal with the unknown but ever likely pathogenic outbreak, disease X. That is to say, having prototype vaccines and therapeutics in place for dealing with an unknown pathogenic outbreak that might, of course, come to pass and would require that entire system to be recalibrated towards a new disease. Would you agree?
Well, I'd agree in large part. By its nature, of course, the next pandemic will be caused by a novel pathogen, so that preparation can't be done perfectly by its nature. I think where the greatest gaps were in terms of that response, which we learned a huge amount because of the success of the vaccine program, but we must retain that learning and retain those capabilities and indeed strengthen them now in peacetime, is especially in the manufacture. And I mean that in the broadest sense, from the ability to target a vaccine platform at a new pathogen. That part happened pretty quickly, and I'm sure would happen again pretty quickly. The bit that needs acceleration is essentially everything from there onwards. Through clinical trials, we should have the use of challenge trials ready and available with all of the ethics codes signed off in advance, which we didn't have last time. The accelerated regulation, which the MHRA did do absolutely brilliantly, but since the pandemic, they've gone backwards on how quickly they do that, that needs to be fixed. And then the manufacture all the way through to fill and finish, where there was an assumption that it didn't matter where that happened in the world within the system, because in normal times it doesn't. And one of my contributions was to say the moment a vaccine gets signed off, there's going to be enormous demand and geopolitical level demand for this. And therefore, having that manufacture and fill and finish onshore physically within the UK is critical in the way that it simply isn't in normal times, because governments will take a very strong interest and use extraordinary measures, as indeed we saw, especially from the European Commission. And so making sure that we don't forget that we build that capacity now is critical.
And before we leave the topic of research and development, in terms of vaccines, how important is it that there is a capability to research and develop and ultimately authorize a prototype vaccine that can be tailored towards a particular pathogenic outbreak?
Well, I think that is important, but I wouldn't say it's the most important item on the critical path. So I have a very strong view post-pandemic that we need to have a vaccine available as soon as possible. And I think the goal of having a vaccine available to any reasonably expected pathogen within 100 days at scale is the right target. I know that's also become a sort of G7 objective, but I mean this about the UK policy should be for the UK to be able to develop and manufacture and be ready to deploy a vaccine at scale within 100 days. That should be the UK government's
but that's a policy, and so that everyone can understand, the 100-day mission is something that was propagated by the UK government when it was in charge of the G7 a few years.
But I kind of don't care about the G7 element of it. I care about the UK element of it, and it should be the UK government policy for the UK, irrespective of who else we also encourage to come with that.
But it's a policy. Yes. No policy will succeed, Ms. Hancock, unless there is the research and development infrastructure there to make it work. And in terms of vaccines, there needs to be, does there not, a continued focus on developing prototype generic vaccines that can be used and tailored for any future outbreak, disease X or whatever.
Yes, I suppose the reason I was giving the broader answer is that is one small part of a much broader set of things that need to be in place in order to be able to hit that target.
Quite so, but we're only looking at research and development at the moment.
Okay.
In terms of therapeutics, did your time as Secretary of State cause you to appreciate that in terms of the development of new therapeutics, it was vital to have a platform capability, that is to say, a research and development infrastructure that could develop new therapeutics, as well as having a system in place for their platform trialing. For example, recovery. To have a system that you could use to trial therapeutics effectively and at speed.
Yes, it's absolutely critical. Again, recovery was put in place very, very quickly, and in my view, is the most successful clinical trial in the history of clinical trials, because it was done at such scale and such pace. Again, unfortunately, and much more so than on the vaccine side, that capability has degraded very significantly since the pandemic. And
can you say why?
It's very hard to know.
In what way?
It's broadly, I think it's probably a combination of the pressures on the NHS, the day-to-day pressures, meaning that the priority of clinical trials is lower when there's so much immediate challenge. There's definitely a funding issue that needs to be sorted, and there may be an element that's to do with the regulatory system having got tougher. But I think I would strongly recommend to the a future piece of work that is critical, and it's good for the country in peacetime anyway, but critical for pandemic response is to ensure that our clinical trial capability is stronger. The Lord O'Shaughnessy report into this 2 years or so ago gives a good indication of the sorts of things that need to happen.
Yes. And then finally on this topic, you've mentioned vaccine manufacturing capability, onshore vaccine capability, that is to say, within the United Kingdom. What was the general state of the UK's manufacturing capacity in early 2020?
It was weak. We'd been working to try to build the JMIC and to try to enhance that capacity before the pandemic. and we had to accelerate that very aggressively from the start of the pandemic before we knew that a credible vaccine would be available. But thankfully, it's something that Jonathan Van Tam in particular had a very strong background in, and we were able to do as much as we were able to, but it still wasn't perfect because a whole load of our vaccines still were manufactured on the European continent, and that caused us significant problems when they chose to behave extremely badly over the distribution of that vaccine.
We don't need to go into that.
Well, we do actually.
Well, Mr. Hancock,
because it happened and it caused us enormous problems.
Yeah. It's not within the scope of this inquiry to delve into the relationships or the arrangements with our European colleagues.
But I take the point that we need to have the capacity to do it here if you're going to have a pandemic which is global.
Yes, and my only point, I don't want to get into the details of the EU brouhaha, but the point is that even if you have a legal contract, if the manufacture happens offshore, force majeure will be used by other organisations, whether it be... I actually was more worried about the Trump administration, which is why I stopped the Oxford vaccine going to Merck for the US. No,
Sorry, this is my fault. We now go...
No.
But it's important. But it is
Mr.
not
Hancock,
outside, with respect.
No. Forgive me, Mr. Hancock. We've got very little time, and I'm afraid you have to focus on the questions.
Yes, but
we'll come back to the question of manufacturing capacity at the end of your evidence.
Yes.
I'd like to ask you, please, about the research call process, which was the first stage in the getting ready process at the beginning of 2020. You received a submission on the 31st of January recommending that a research call process be put into place. We'll have that, please, INQ 4057497, page 2. Essentially, was this position that you were asked to note and obviously to lead and to encourage and assist a process by which a research call could be put out to academia and industry as rapidly as possible in order to be able to commence and provoke the process of research and development?
I'm afraid I'm going to complete my answer to the previous question because it is not out with the scope of this inquiry, which is very broad, to consider the ways in which a domestic vaccination programme could be knocked off track. And I would insist that that is an important part of the inquiry and is important to look into and to make sure we don't fall into that trap in the future, hence the need for domestic manufacture.
All right,
now, on this question, as you put it, is exactly what we were trying to achieve. On the 28th of January, I asked for money to be made available for research for vaccines and therapeutics, and this note was the result of that request.
Can I just pick up one or two of the points, please, in this document? This approach was obviously greatly contributed to by the Chief Medical Officer, Professor Sir Chris Whitty, and the DCMO, Professor Sir Jonathan Van Tam. We can see from paragraph 3 something of the bodies that were concerned in the funding side. Obviously, the DHSC was the overarching body, but we can see the references to the MRC and the National Institute of Health Research, now the National Institute of Health and Care Research. Was it your view that everything was generally done as far as was reasonably possible in terms of trying to identify who could carry out the essential research and development, and also that the funds were made available by government and through these bodies for that research to be done?
Yes.
In the course of the following 2 months, your department received multiple requests or multiple notifications that requests for funding had been made, and they all generally received the support of yourself and your department. In the course of the debate, however, much was said about the need for the United Kingdom to present itself as an expert clinical testing site in order to assist the manufacturers who would commence the production and the manufacture of vaccines and therapeutics. why was having a proper clinical testing infrastructure so important to this process of identifying vaccines and therapeutics and getting them produced, manufactured and delivered?
Because it is vital to base your decisions on vaccines and therapeutics on proper clinical science. And given the desperation for solutions, there were many solutions put forward before they had clinical validation. Most famously, the idea that hydroxychloroquine could protect you from the impact of COVID. And I was very strongly of the view, of course supported by the CMO and the scientific bodies, that we needed to make sure this was based on science, and clinical science requires clinical trials to validate. And the bigger the trial, the more power in it, and therefore the quicker you can get to a result. So it was, and the UK is one of the few countries in the world that can do this at scale.
And the manufacturers have to be able to have their products tested.
Yeah.
And so the more that can be done by, for example, the United Kingdom, to test possible therapeutics and vaccines, the greater assistance it will be to the manufacturers.
Yes, and not only the manufacturers of new drugs, but as we discovered, it was the repurposing of existing old drugs that actually, with dexamethasone in particular, came to the fore in a life-saving way. So this was directly on the critical path to saving lives.
And so if we look at this page, in particular paragraph 5 at the bottom, the cause will contribute to the global response by actively collaborating with and being informed by the WHO's Global Coordinating Mechanism for Research and Development and GLOBE-PIDR and KEPI. So being well prepared to carry out the clinical testing, being well prepared to fund the testing and the clinical development was not only of assistance to the manufacturers, but also hugely contributed to the global response as well.
The UK and the global response, absolutely, yes.
All right. In terms of therapeutics, there's much written evidence before the inquiry, particularly from Sir Jeremy Farrar, Professor Sir John Bell, and Dame Kate Bingham, that by contrast perhaps to the overall coordination of the vaccination research and development, the vaccine research and development, the system by which the trialling, particularly the phase 2 trialling of therapeutics, worked rather less well. There were a great deal many trials. There were a lot of academic bodies perhaps tripping over each other. There were a number of wide-ranging disparate interests from industry, and it didn't appear to have the same degree of coordination as the vaccine research and development. Would you agree?
I don't actually agree with that. The programs were run differently. On therapeutics, it was run much more within the department. It didn't need the breadth of scope. There's a perfectly good debate that we can have about the value of bringing in highly capable independent externals with given a huge amount of authority to do specific tasks, like Kate Bingham specifically on the commercials around vaccines, which she did brilliantly. When it came to therapeutics, it was much more about getting an excellent set of clinical trials in place, and with recovery, we put in place an absolutely brilliant clinical trial. It is by its nature a messier area in therapeutics, so I can see why it might have looked like that, but it was still incredibly effective.
That may be so, but it's apparent from this evidence that it didn't just look like that. There were too many underpowered phase 2 trials. There was a degree of tension between the DHSC and the BEIS, the two government departments, over who was in charge, and also a real problem with recruitment, because there was an absence of proper coordination and management in terms of getting people into these trials for therapeutics. You must have been aware of that.
Yes, but I was also aware that we were running the largest, fastest recruited trial that had ever happened, and came up with the first clinically valid therapeutics. So I think it's quite hard to. So at the same time, it's possible to say yes, it could have been done better, but it also worked very, very effectively and saved many lives. The same is true on the vaccines side. There are many points of detail which could have been done better, but it worked overall very, very effectively because of the effective coordination and teamwork between the 4 groups I spoke about earlier.
Quite so. We're looking to see how it could have been done better.
Yeah. But from my seat,
yes.
I didn't really. I don't.
It was
really
going as well as you
recognise
thought it reasonably could.
That's right. Even if there was, there's always noise under the surface in these things when you move very, very quickly.
It's obvious that there was a debate about whether or not therapeutics generally, as opposed to neutralising monoclonal antibodies, should be within the remit of Dame Kate Bingham's vaccine task force.
Yeah.
And ultimately, the position was reached that monoclonal antibodies would be within the task force, but therapeutics would go off to a DHSC, entirely DHC body, the Therapeutics Task Force. So it didn't have ultimately the same degree of external influence as Kate Bingham's vaccine task force. Do you think in future it would be better if the Therapeutics Task Force was to be put together, if it is utilised, in the same way as the Vaccine Task Force was utilised by and managed brilliantly by Kate Bingham?
Well, remember that the therapeutics work was managed brilliantly by JVT. So we had very strong leaders on each. It was very clear to me as Secretary of State who I went to in each case. And it's perfectly reasonable on the therapeutics side to point to points of detail that could be improved, but overall it was absolutely brilliant. Precisely the same analysis applies to the vaccines. There were debates about exactly how many we needed to order. I thought we needed to order for the whole population. Some argued only for a subset of the population. It is correct to have these debates, and entirely reasonable, and that happened on both sides. So I don't really buy this distinction you're trying to draw. Having said that, I'm a big fan of the strongly led, bring in the experts model. And I think the more external expertise you have working alongside civil servants, the better, so long as the accountability is right and the direction of travel and leadership is set. And I think the VTF demonstrated that.
You've referred to the process of procurement and obviously the range of vaccines that the Vaccine Task Force was able to procure. I was asking you, though, about the system by which government puts into place a body or an entity to be in charge of it.
Yeah.
So can I press you on that? It appears to be generally accepted that the VTF did extremely well. The Therapeutics Task Force and its successor, the Antivirals Task Force, did very well also, but there were distinct problems, it would appear, about the coordination and management of the clinical trial process and the way in which antivirals and therapeutics were procured ultimately. The system did not move and work as smoothly as it had for vaccines.
No, I reject your characterisation into 2 different groups. Both worked brilliantly, had clear accountability from where I sat, and both had an enormous amount of work going on underneath, some of which was noisy, and there were reasonable disagreements about process, and there were things that could be improved. For instance, if you look back, there was an enormous amount of noise and criticism around some of AstraZeneca's clinical trial work during the summer of 2020, especially when the case rate fell very low in the community. And that was on the vaccine side. So I just think you're wrong to characterise it as one went really well, one went really badly.
No, I didn't know, Mr. Hancock.
You
I
literally
said they
asked
both went.
that.
No. I said the vaccine task force operated extremely well, or very well. I said the therapeutics task force overall also worked very well, but there were problems.
But there were on the
there
were on the vaccine side as well. And what we did was we worked through the problems that we found. And then you also asked about the boundary between the two and where antivirals found. In essence, my view was it didn't really matter which side where the boundary lay, so long as it was clear. And I remember, for instance, Kate Bingham was very clear to me early on that she thought that it was unlikely we'd get a vaccine in good time. So she wanted also to work on antivirals because they may be the solution. And so I thought, given that enthusiasm, she could do that part and put antivirals on that side of the fence. You could have cut it either way. But the inquiry would be wrong to conclude that this bifurcation in one went well and the other one didn't, or even though both were a success, one didn't have problems and one did. It's just not true.
Were you aware of quite heated emails within your own department between your officials concerning whether or not the general topic of therapeutics should be amalgamated within the vaccine task force?
Yes, I was aware of the debate. I'm not sure I've seen the emails, but there was an entirely reasonable debate about how best formally to structure these things.
Do you acknowledge that some, rightly or wrongly, take the view that because therapeutics, other than monoclonal antibodies, were out with the vaccine task force, there was a perception that the government cared less about therapeutics and vaccines? I'm sure you've got something to say on that.
I disagree, and I don't really care about the perception. I cared about the substance, and the substance was that we discovered that dexamethasone saved lives before anybody else did around the world, and the Therapeutics Task Force did brilliantly and had very clear leadership, and could and there were areas where it had to debate things and there were difficulties that it overcame, and that precise analysis applies to vaccines as well. Just because one side is more puts their points more forcefully afterwards doesn't make it true.
I mean, you would say, I presume, that therapeutics at a population level are less likely to be able to bring a country out of a pathogenic crisis than vaccines. Vaccines had to be looked at with no less degree of importance than therapeutics.
They were no less important, absolutely, because the importance of them is different in nature because of the fact that the vaccine can get us out of a pandemic. But the therapeutics more directly saved lives because people going into hospital with COVID-19 were a third less likely to die after the successful clinical trials of dexamethasone. So so one has a more direct impact, and one has a more macro impact, if you like. So the impacts are different in nature, but that doesn't. So it's impossible to say which is more important. They're both incredibly important.
Indemnities. The VTF, which obviously fell within the government department, BEIS, business, enterprise. I can't now remember the acronym.
And industrial strategy.
Innovation and strategy.
Industrial strategy.
Thank you. And obviously with the DHSC, had to negotiate with the manufacturers. And that included having to negotiate the question of indemnities.
Yeah.
Is this the position? Broadly and understandably, all the manufacturers sought indemnities of one sort or another. Was the issue of indemnities resolved generically, or did they have to be individually negotiated with respect to each manufacturer?
So I wasn't involved in the individual negotiations, but my understanding is that they were negotiated individually, and that would be reasonable. For instance, AstraZeneca was not taking any profit from the vaccine, and therefore it would have been unreasonable to ask them to bear an uncapped risk at the same time as essentially doing something for the public good. And my view was that the state was the insurer of last resort,
and therefore needed to step up in this way. So I was broadly sympathetic to the need for indemnities, which were, of course, only to indemnify should a court case be lost. It wasn't a blanket.
We'll come back to that in
Okay.
a moment, because that's a very important point, Mr. Hancock. The manufacturers, or some of the manufacturers, initially sought full statutory immunity, that is to say, a process by which they couldn't be sued at all. And it's right to say, isn't it, that that was rejected by UK ministers and ultimately came to nothing. But what was done was that an indemnity provision was agreed whereby nobody would be precluded from going to court and suing a manufacturer, for example, under the Consumer Protection Act. But if the company lost, in certain circumstances, the government would pick up the tab for any award of compensation as well as the legal costs. Is that a fair summary?
As far as I recollect, yes, although, again, I wasn't involved in the precise negotiation of these.
In general terms, I don't want to get into the specifics of the indemnities that were agreed, but was the position taken by the United Kingdom particularly or significantly different from what ultimately was negotiated between the manufacturers and other, particularly Western European countries?
I don't know.
All right. Do you consider that ultimately what was agreed with the manufacturers in terms of indemnities was reasonable and proportionate, given the need to get vaccines manufactured and developed?
Yes.
Right. Evusheld. You've referred to Evusheld. Evusheld was, I think, Project Astronaut. It was also known as AZD 4722. And just by way of summary, in June 2020, you'll recall that the Vaccine Task Force agreed provisionally with AstraZeneca to buy a large number of this drug, a long-acting antibody. And that was announced, in fact, by the government in July 2020. Subsequently, the Vaccine Task Force wrote to, in particular, Professor Sir Chris Whitty and Professor Sir Jonathan Van Tam and Clara Swinson in your department, asking for confirmation as to whether or not that prospective advance purchase of Evusheld should be confirmed. And we'll have up a document, please, INQ 000497987. A body called the VTF Panels Team wrote to yourself and a number of others on the 17th of February 21, enclosing an attached decision paper for ministers. That's obviously you and Alok Sharma.
Steve Barclay.
Oh, Steve Barclay, thank you.
The VTF reported to the three of us, yeah.
Please find attached decision paper for ministers on whether the VTF should proceed with the advanced purchase of astronaut antibody treatment. The VTF recommendation is that ministers agree that VTF should not proceed with the purchase agreement. Did you, in fact, receive a number of papers and documents from the VTF and also from the Office of the Chief Medical Officer about the merit of proceeding with advanced purchase?
Yes. This was a live discussion because of the importance of antivirals. I mean, the antibody treatments, because we knew that the vaccine would not be medically suitable for everybody, and yet we needed a solution for everybody. And in fact, I was at the forefront of the argument that we needed a protection for everyone. Some people said we should only protect the clinically vulnerable. I believed and strongly believe, with hindsight, that it's right to protect the whole population. If you can't take a vaccine, therefore you need another protection. So I was keen to find an antibody treatment that would work. But when the clinical advice says that we should not proceed, that is obviously a reasonable clinical decision.
And was the advice from the VTF, was the advice from the Office of the Chief Medical Officer, the clinicians and the policymakers all in fact pointing in one direction, which was, for a number of reasons, this advanced purchase should not be made?
It was clear and unambiguous on the clinical grounds. My recollection is that it was because the shelf life was relatively short, but it was going to take several months before we had clinical validation, and therefore if we bought at that point, we weren't to know whether clinical validation would come forward, and if it did, anything we'd bought early would by then be out of date. So it was a essentially logistical clinical decision explanation that was given to me behind the recommendation not to buy. And when faced with unambiguous clinical advice, I tended to follow it.
And there were a number of other reasons, which I'll summarise for you. Professor Sir Jonathan Van Dam in particular said, given the background of the emerging success of the vaccination programme, the need was perhaps to some extent, not a great extent, reduced. There was also a lack of clarity as to how many people might benefit. It was a relatively expensive purchase, but that it was important to keep the whole decision under review, particularly for treatment purposes after the event.
Yes, remember, this is a decision, the one in front of us is not a decision not to proceed with an advanced purchase before clinical validation. I have friends who couldn't take the vaccine for clinical reasons. I understand why there was a big push for that by those in that position, and I agreed with that. But there's no point in buying something that might not work if the clinical advice is not to, because if we buy it now, anything we actually physically buy now won't be available because it'll be out of date by the time it could be used.
There are many people who have suggested to the inquiry that thereby the immunosuppressed and others who would have benefited from it were essentially ignored or abandoned. And I want to make it plain. Can we have, please, INQ 4066717, that although the decision taken by ministers was not to proceed with this advance purchase, they were keenly aware of the need to strategise for and provide for the immunocompromised who can't take the vaccine or might not be protected by the vaccine, and how they were to be protected.
There you are.
And was there, in fact, in your department, considerable work done on, firstly, thereafter, setting out further and developing further the prophylaxis trials which were already underway, trying to identify the number of immunocompromised who might benefit from an advanced purchase of a prophylactic treatment, and also putting into place some other new trials. I think there was a trial called Protect V and another trial called Protect CH. So the issue was not forgotten.
Far from it. We continued to push for this, and I remember regarding this decision as a decision not now, rather than a decision not ever.
And therefore, you would agree, no doubt, that although a number of people, including Dame Kate Bingham and Clive Dix, described the decision as a serious mistake, there was material before ministers on clinical and other grounds or other reasons for the decision that they took.
Well, it's entirely reasonable that people can differ in their opinion on the on any of these decisions, which were each big decisions. But the clarity of clinical as opposed to non-clinical advice, so if the advice from the commercial team that you mentioned was in favour, if the advice from the clinical team is against, and we're looking for a clinical solution, you can understand why ministers took the decision that they did. But I held Kate and Clive Dix in great esteem. It's totally reasonable for them to have held a different view. But what we were trying to achieve was the protection of the immunocompromised in a way that was clinically effective.
On the subject of prioritization, that was obviously an issue primarily for the Joint Committee on Vaccination and Immunisation, JCVI.
But that wasn't a passive decision. That was we took an active decision to invest in the JCVI, the authority to make recommendations which they should rightly expect us to then have followed.
Right. We don't need to go there, Mr. Hancock. I was going to ask you about two particular aspects of prioritisation with which you were directly concerned, out with the general structure, which is that prioritisation was for the JCVI to determine and implement. There was an issue in February 2021 about the definition of cohort 6, that's to say, number 6 in the list of prioritised groups in the phase 1 priority list issued by the JCVI, which concerned those persons who are in receipt of a carer's allowance or those who are the main carer of an elderly or disabled person whose welfare may be at risk if the carer falls ill. And there was quite a complicated structure in place because there's also something called the Green Book, which is a semi-medical publication which gives a description of, amongst many other groups, adult carer. Did an issue come to the fore which concerned you ultimately, and you had to take a view on it, as to how well defined that cohort 6 was and whether or not unpaid carers should be the subject of a definitional change? Do you recall?
I recall this issue very clearly. The bit of your question that I don't quite agree with, I put it a different way, is that it was an issue that came to the fore. It wasn't an issue for my final decision because I'd already decided that we should follow JCVI advice, whatever their advice was. We asked them to take into account the practicality of implementation as well as essentially their central goal was to take a scientific view of how to save most lives through the prioritization. And that's why, for instance, we didn't go down a sector-by-sector approach, teachers, policemen, etc., because more people would have died compared to doing it essentially by age and then bringing in clinical prioritization of other priority groups only when their vaccination would save more lives than moving on to the next age cohort.
Could we have INQ 4059858? This is a submission dated the 9th of February 2021. It's to the Secretary of State, and it concerns this issue, cohort 6. If you could go over the page, please, to page 2. There we are. It's to the Secretary of State of Health. And the recommendation says, we recommend that you note the method of implementation, you agree to the proposed definition, you agree to the prioritisation of the individuals under multiple occupancy settings, and then note a final issue. So although it was primarily, as I suggested to you, for the JCVI, as the Secretary of State, you were undoubtedly, nevertheless, being asked to agree to the change in the proposed definition of unpaid carers. But as you say, this was something very much within their expert subject matter.
Correct. It was my formal authority to make this decision. However, having asked them to come forward with advice on what is the best way to save the most lives, I then took that advice rather than second-guessing it.
A second issue which came to you concerned people with learning disabilities. In your diaries, your book, you refer to quite a difficult issue in February 2021 concerning whether or not only those with severe learning disabilities were getting prioritised. And there was a real problem with whether or not local GP registers and other NHS systems were properly recording who suffers from learning disabilities.
Yeah.
Do you recall how that was resolved?
Well, my recollection is that this was a really important boundary issue. All of these are difficult judgments on where the boundary with a group should be, given that the people who are deemed within that boundary then get access to the vaccine, which is life-saving and incredibly valuable. I know about the area of learning disabilities very well, not least because I'm a campaigner on neurodiversity. I am dyslexic. That is technically a learning disability in some senses. I did not deserve an earlier vaccine because of my dyslexia, but those with severe learning difficulties were dying at a greater rate than the general population, and it was evident that you could save more lives by ensuring that they did. Where is the boundary between a perfectly fit and healthy dyslexic and somebody with perhaps with permanent inpatient care with severe learning difficulties? We had to find a boundary somewhere.
Was it apparent to you that the foundation of this problem and what became a definitional debate lay in part in the fact that GP systems, the data systems at GP level, didn't always capture the severity of someone's learning disability?
Yes.
So it was impossible for anybody to say they are entitled to prioritization because they have condition X,
Yes.
whereas Y doesn't, and therefore...
Yes, yes, and it's even worse than that, because many learning difficulties and disabilities are defined essentially educationally, and in the world of Whitehall and the UK government system, that becomes a piece of data in their education record, not in their health record. And so if you go into their health record, you might not find any reference to it. So it's a very complicated area, and frankly, it could do with a huge amount of improvement.
Well, this is what I want to ask you. There are obviously a huge range of issues here, from the simple fact of accuracy of recording to the integration of data systems.
Yeah.
As well as, of course, whether they record disabilities and medical conditions, as well as sectorial differences, ethnicity, and the like. But can you help us with this? When this problem about registration in GP registers of severity of learning disabilities came to your attention, was anything done at that stage concerning the operation of these data systems? Was it possible to address the overall system at that time in the teeth of the pandemic? Was anything done to try to improve the overall efficiency and accuracy of this system, the GP registration system?
Yes, I mean, throughout the pandemic, as we've heard in other modules, there was a huge amount of data work done to progress the quality of data that was available to government for these sorts of purposes, whether that's in the shielding programme, or in the measurement of the vaccine, the virus itself, and the NHS, etc. This is another area where there was some improvement, but there's still a huge amount that can be done to make these sorts of data sets more interoperable.
That brings us on to the wider area, if you like, of barriers to uptake, quality of access to vaccination, because plainly, and it's obvious, despite the overall success of both programmes, there are very real difficulties concerning delivery and access. We needn't go into the detail of it. It is obvious, and we could have perhaps INQ 000256951 up, that a great deal of work was done by the UK government in particular, because of its overarching position, but as well as by the devolved administrations, on trying to identify the basis of vaccine and health inequalities. How do you make the prioritisation programme and the delivery programme work better?
Yeah.
At a very high level, Mr. Hancock, would you suggest, or do you think that as much was done as could reasonably be done by your government, the UK government, to address the issue of barriers to uptake and problems with access, not with practical delivery, distance to vaccination or eligibility for therapeutics, but with the general state of play on why there are so many people who didn't realise that they had access or they were entitled to access, or didn't take up vaccination, or were prevented in one way or another from doing so?
We put a huge amount of effort into this, from before the vaccine was signed off. I kicked off a piece of work in June or July 2020, for instance, talking to the social media platforms and learning, having been the culture secretary before, I'm responsible for this sort of area in general policy terms, and then trying to really understand how you could drive up take-up. The central insight that we had was that you just can't think of people who are distant from following the recommendations of the state as hard to reach.
you have to think of them as the state being far away from them. You've got to see it through their eyes. And if you think about, there are many communities where there is just not the history of relatively high trust levels that, although we knock ourselves about it in the UK, we have very high trust levels in authority like the NHS, the royal family, the BBC, and to a lesser extent, the wider government. There are communities where that is simply not the case. And we learned a huge amount through the rollout. For instance, if you'd look at maps and there was high vaccination set right next to low vaccination rates, and you'd find that even within ethnic minority communities, the single biggest determinant of the likelihood of a community who may be more hesitant than the general population to take the vaccine is the ethnicity of the vaccinator. So you might have a Hindu vaccination centre. Everybody was eligible to go there, but it may have been run largely by people with a Hindu background next to a largely Muslim vaccination population, and they may be less likely. But if you then put a team, if you then put a vaccination centre into the local mosque, then you get the pickup on the Muslim side. So that is one example. We saw that precise example. That is a description of what happened in Leicester. And we learned a huge amount about how to make the state as open as possible to those who we were encouraging to come forward for vaccination. And you may want to ask Minister Zahawi, former Minister Zahawi, because I know he's appearing and he led a lot of this work, as did Sadiq Khan.
Can I just interrupt for 1 second? One of the issues raised in the Every Story Matters records, a number of contributors raised it, and I've heard it again in evidence this week, was the issue of misinformation, particularly on social media, and you've just mentioned social media.
Yeah.
This was obviously something that you knew about at the time.
Yes.
What steps, if any, could government take to try and counteract that misinformation?
We did a huge amount of work on this as well, and so we engaged early with the social media platforms who rose to the challenge, and the mainstream media, including the BBC. But where we really learnt from was the work that had been done to tackle misinformation around ISIS, Islamic State, because what we learnt there, what the UK government learned, was that if you directly disagree with an anti-vaxxer, then all you do is amplify that anti-vaxxer's view. And we segregated the population in terms of enthusiasm for vaccines from there's active anti-vaxxers who try to actively persuade other people not to take the vaccine. There's very, very few of them, but they feel it incredibly strongly. Then there's a large number who are vaccine hesitant. For them, you need to have enormous amounts of sympathy because they are willing to take a vaccine if they could be persuaded. Then there's the broad centre of population. Then there's the broad enthusiasm. Then there's the super enthusiasts. And you need the enthusiasts to be out there making the case, but you want to basically ignore the hardcore anti-vaxxers and then use positive counter-narrative to persuade the hesitants. And the most useful tool we had to do that was positive, objective, scientific-based, but well-communicated messages from the NHS, because it's such a trusted brand. And so that's so where we found pockets of anti-vax on the internet, on social media and what have you, we inserted into that positive factual counter-narrative, which effectively meant messages from the NHS about the value of vaccination. But it was so important that they were true and verified, and because otherwise all you'd be doing is giving more succor to the hardcore. I always thought it was about 2% in my head, the people who really, really are trying to stop other people get vaccinated, not just worrying about it for themselves.
May I just bring you back briefly to my question, because we understand you've obviously got a great deal of learning about the topic, but my question to you about barriers to uptake and inequalities was actually focused on whether you assess, and it's an extremely complex and difficult area, but do you assess the government did enough to try to reduce barriers and reduce inequalities? And I say that because It's obvious, Mr. Hancock, a great deal many elements in the government, the UK government, from the discrimination unit, the NHS, the Public Health Agency, PHE, BIS, DHSC, DCMS, we're all focusing on trying to address this problem. But it's quite a fragmented, it appears to be quite a fragmented area. Do you consider that enough was done, that the government did as much as it reasonably could to try to tackle this problem?
Yes, we did everything we possibly could. Yeah, and of course, I'd leave no stone unturned. If there are other things we could have done and that should be done in future, great. But we did everything we possibly could in this area. We anticipated it would be a problem in advance, and we worked incredibly hard. And you mentioned a whole series of different parts of the government. It wasn't uncoordinated. It was just there was a lot of activity going on, and then I'd say there were broader elements. The palace, the Her Majesty the Queen, the late Queen, did not typically disclose any of her medical details, but she did disclose that she'd been vaccinated, and that was a very positive proof point. So we brought every part of the panoply of institutions that we could in order to persuade people of the scientific facts and truth, and the proof of the pudding is that we got one of the highest vaccination rates in the world, and I'm very, very proud of the team, the work they did on that.
All right. I'm not sure about the link between the late Queen and barriers to access and ethnic minorities.
No, on the contrary, no, really, it had a huge positive impact because she's a trusted figure.
I want to conclude just by putting to you, please, some of the suggestions and recommendations in your sphere, your former sphere, the DHSC, which have been suggested to the inquiry, to get your brief take on them. The first one I want to ask you about is the possibility of a national vaccines agency. It was specifically recommended by the VTF recommendation document in December 20, and it's also been promoted by Dame Kate Bingham herself, by Clive Dix, and by a number of people who worked in that sphere. Would you support the creation of a national vaccines agency to deal end-to-end with the process that the VTF itself dealt with in the course of the pandemic, from threat assessment, clinical development, capability, scale-up, and procurement, not delivery, but up to procurement, so that next time there is a body already in place to do the role of the VTF?
Well, we now have that body, which is the UK Health Security Agency. It is absolutely UXA's role. And if all of those elements that you just mentioned aren't within UXA, they should be. Whether you then want within UXA to have a specific unit for vaccines, I'm pretty sure you do. What I wouldn't do is have a separate agency, because you can already see in peacetime the challenges even UXA has of getting money out of the Treasury, frankly, to make all this happen. Their budget is not nearly high enough given the scale of the threat from H5N1 and other pathogens right now. So for that reason, I wouldn't have it as a separate agency where it would wither on the vine. But the principles behind why you'd want a separate agency, i.e. independence of voice and capability that you can bring in, I'd have, but I'd locate it within UXA.
The point about the VTF, of course, Ms. Hancock, as you well know, is although it was ministerially accountable to Parliament through BEIS, it had that degree of external expertise through Kate Bingham, Clive Dix, and a number of other people, such that it had, and you gave it, this degree of independence so that it could operate out with some of the well-known strictures of Whitehall. So isn't that what needs to be replicated next time?
That's what UXA should do, yes.
All right, because it's not what, of course, the Therapeutic Task Force had.
Yes, I'm going to come on, because you pushed me on this a lot earlier on the Therapeutics Task Force. I think it's really important for the inquiry to take into account the fact that because the therapeutics area was driven by civil servants, they are less likely to have a voice now in making an argument for how they did things. And this is an important thing to consider across the inquiry's work. Civil servants tend to be dry and cautious in their response to inquiries, as opposed to loquacious
opposed
in
to
the promotion
politicians,
of their views.
Mr. Hancock.
Indeed. We're more freewheeling, I'd say.
Yes, that's one way of putting it. But the point, Mr. Hancock, is it obviously worked, and therefore the more we can do to replicate the bits of the vaccine task force that worked,
Yes.
the better.
Yeah.
All right. A second element, finally, is Dame Kate Bingham and others recommend the institution of a vaccine national research registry to register the willingness of those who participated or want to participate in vaccine trials. Your department played a very important role in ensuring that as many people would come forward for vaccine and therapeutic clinical trials as possible. Do you think that there is an argument for the creation of a separate body to run, monitor and promote participation in trials, not least because of what we were discussing earlier about the problems with recruitment in the therapeutic phase 2 trials?
Yes, I would absolutely support the need for a register. Again, this is, if run well and with the right budget, this is another role that UXA ought to play. But the idea of a register is very important, so you don't lose that enthusiasm. I would add one further thing. I've seen the recommendation here, and I agree with it. The thing I'd add to it that is absolutely vital and doesn't get enough airtime is the need to set up challenge studies and have people who are willing to take part in challenge studies. These are studies where people are intentionally infected, because then you can seriously accelerate the clinical study work.
This was in fact commenced by Clive Dix and Kate Bingham, that they had something called, as you know well, human challenge trials. And I think the DHSC funded £33 million worth of the first phase of that programme.
Yes, I think it was actually JVT who kicked that off, but it was, I'm sure it was strongly
But has it lasted?
I hope so.
All right, but you don't know?
I don't know, but it should.
All right. And my final question, please. You've referred already to the importance of onshore manufacturing capability.
Yeah.
Plainly, there is no one practical measure that can be taken. It's obviously a very complex topic. But what's your general position on this? Do you say that the onshore manufacturing capability in the United Kingdom has gone backwards since the pandemic? Or is your understanding that we are still in a relatively good position when it comes to the existence and presence of various sites of manufacturing bodies who can pick up the mantle in the event of a future pandemic?
We're in a much stronger place than we were at the start of the pandemic. But even during the pandemic, we didn't get to the point where we could manufacture everything we needed. And of course, the speed of manufacture was the rate limiting factor on the rollout of the vaccine. So there is not yet enough. I don't know whether it's gone backwards or advanced further since the end of the pandemic. What I do know is we still don't have enough, and the pandemic demonstrated the vital need for a sovereign capability that is onshore because of the political issues will cause the same sorts of problems in future as they caused us during the pandemic. And critically, one final point on this, back to this debate about how many vaccines we needed. We took the decision against advice to procure vaccines for everybody, for the whole country, which meant 100 million doses in the first instance. That was the right decision, and we are going to need that scale as fast as possible next time, because there is a huge clamour for vaccination when one becomes clinically valid, if it's seen as a route out of a pandemic. I'd want us to be able, as a country, to play the same sort of role as we did last time in leading the charge here and around the world, and allowing many, more than 1 billion people to be vaccinated thanks to the work of the United Kingdom.
Let's leave it there. Thank you very much, Mr. Hancock.
There are a few more questions.
My lady, yes. May I make a suggestion? I know that Mr. Leslie Thomas, King's Counsel for FEMO, has another court appearance at 1 o'clock. I was wondering whether or not...
I think you're a bit tight for time, Mr. Thomas.
Well, he's got 5 minutes, but I know he's second in the list. I wonder whether you might invite him to go first.
If Ms Morris doesn't mind, we'll certainly complete Mr Hancock's evidence before lunch, but we'll take Mr Thomas first so you can... I hope it's a remote hearing, Mr Thomas.
I would be in trouble. Mr Hancock, as you know, I represent FEMHO, the Federation of Ethnic Minority Healthcare Organisations. I want to take you to, you don't need to turn it up, but your witness statement, paragraph 195. There you say this. You refer to trade unions as being unthinkingly against vaccination as a condition of deployment. They will have to answer for their rejection of care, science, and objective fact. I'm sure you remember the quote. Now, question. Do you remember what you said about structural racism in Module 3 and being concerned about it?
Yes, of course I do.
Right. Well, isn't it true that all the unions were doing, in fact, were raising legitimate safety concerns from frontline healthcare workers, particularly from Black, Asian and minority ethnic backgrounds, who faced the highest workplace exposure risks? Isn't that right?
No, they were promoting illegitimate arguments precisely because of the highest infection rates amongst those groups. They would have been the greatest beneficiaries of vaccination, and an anti-scientific approach helped to make it harder for those of us who were trying to save lives.
Well, you say that, but what was being raised was representatives who were raising legitimate concerns, and your approach, the words that you use, disregarded their advocacy rather than engaging with the substance of what the concerns were.
No, that's wrong. You'll see from the paperwork that we engaged deeply with the substance on condition of deployment. For instance, in the notes show that in February 2021, I was cautious and said we shouldn't at that point push for vaccination as a condition of deployment because it was in the early stages of the vaccine program. But then a month later, once the program was much more established, I proposed, and the government took the position of putting forward vaccination of a condition of deployment. I think the difference between us is that you make the point, you put forward that these concerns raised by the trade unions were legitimate. Actually, they were not legitimate because they weren't based on science. The right position that the trade unions should have taken was to join in the efforts to reassure, support, and encourage vaccination for those who were meeting a lot of vulnerable people and who could have had their own health safeguarded, and especially the health of those in their care safeguarded.
Sorry, Mr. Hancock, can I just slightly push back on what you've just said? Because we are going to hear from the next witness, Professor Heidi Lawson, who's the vaccine hesitancy expert, who dedicates a whole section of her report to the safety concerns among ethnic minority groups, which centred around long-term, unknown side effects from the vaccines. She's going to give her evidence shortly. Whole section of her report. So these were legitimate concerns.
No, the vaccines were valid and safe and saved lives.
No, that's not. Sorry, forgive me. That's not what I said. I haven't said that the vaccines were not valid or did not save lives. I said that you were dealing with legitimate safety concerns. There's a difference.
Yes, and that's why we took a careful approach to bringing this in. But the idea that because somebody is hesitant, you should therefore not ask them to get vaccinated is, in my view, wrong.
No, nobody said that. What's been
The
suggested
trade unions
is...
said it.
No,
that's
no,
why. That's why I objected to the proposals that they made.
Forgive me. What has been suggested is there be better messaging, better communication, so that people can better understand.
Yes.
Bring people along.
I was in favour of all that as well. Absolutely.
Milady, thank you very much.
Thank you, Mr.
You will
Thomas.
excuse me.
I will. Try not to run too fast, I might trip over. Ms Morris.
Waiting for the green light. Thank you, my lady. Mr Hancock, I asked questions on behalf of the COVID adverse reaction and bereaved groups. And these groups represent those who have suffered injury or bereavement following their voluntary acceptance of the COVID-19 vaccines. First of all, do you acknowledge that there are people who sadly suffered injury and bereavement as a result of accepting the vaccine?
Yes, of course.
I'm going to focus my questions today on the issue of pharmacovigilance, and specifically what systems were in place at the time of the rollout of the vaccines to identify and monitor occurrences of adverse effects and whether they were in fact needed improvement. I understand. So my first question, at the time of the vaccine rollout, who, to your understanding, was responsible for overseeing the pharmacovigilance going forward? Was that the DHSC or other agencies?
Well, the majority of pharmacovigilance occurred within the NHS, and the NHS yellow card process was there to capture any adverse reactions, and then a data system was put in place to make sure that that information was fed in, and it came to me through the Chief Medical Officer, if I recall correctly. It was something we cared a lot about, we put a lot of effort into. In the first instance, the data processes were imperfect, but we improved them over time.
It's that kind of first position I wanted to ask you a bit further about, please. And can I ask you to look at a message exchange between yourself and Professor Sir Chris Whitty on the 9th of January 2021, INQ 000129666, please. Thank you. You'll see there.
There you are.
The WhatsApp messages there, you ask Chris Whitty, how strong is our pharmacovigilance system to check the systems post-rollout? I was told, and I think that means that means DHSC, we're doing it, but I'm worried that the details will be shonky. Chris Whitty goes on to say they're reasonable, but they need to get better.
Yes.
And he then says there will be cases.
Yes.
Now, I can ask Professor Sir Chris Whitty about that, but did you interpret him to mean there will be cases of adverse reactions?
It's unclear from this whether there will be cases means there will be cases of adverse reactions, although we knew that there would be.
Yes.
Because there were in the clinical trials. The question with a vaccine is whether it is net positive in expectation of taking it. And they were only approved where they were net positive. Hold on, but he may have been referring to there will be cases like Aradazai where somebody gets a case after vaccination because that was also at the time not known the extent to which post-vaccination people would get COVID. And of course, we now know that people did regularly get COVID after a vaccine, but it tended to be much milder.
Sure. But you would accept, you knew there would be cases of adverse reactions.
Yes, of course.
They were known about in the clinical trials.
And measured, yes.
And that's why it's important to have an effective post-rollout monitoring system.
Yes.
But what did you mean by shonky?
I was worried about the data collection systems and how that would be reported. And as Chris Whitty went on to say, reasonable but needs to get better.
Okay. So what specific examples or evidence did you have at that point that you had in mind when you used the word shonky? What was the sort of concerns you had?
The thing I was specifically concerned about was that you needed to make sure that when people had an adverse reaction, they reported it. And that those reports then fed into a data collection system that could assess the net effectiveness of the vaccine.
We came to see the pharmacovigilance system as effectively like a phase 4 trial, as in you did the first 3 phases, reached formal clinical validation, did the rollout across the population, but we kept essentially measuring the effectiveness of the different vaccines all the way through, and that's what led to the changes in the recommendations around the use of the AstraZeneca vaccine, for instance, that came later in I think March in 21, because effectively we were measuring those responses. In order to get that data accurate, you need to make sure that adverse responses are notified.
And the system has to be signal sensitive, doesn't it, to pick up those adverse reactions quickly?
Exactly.
So what assurances, if any, were you given about the system's effectiveness at the time of the rollout?
As you can see, this is a subject that I was querying my clinical advisors on. As we see at the bottom of this page, who's best to talk to improve the operationalisation of it? JVT and Susan Hopkins. Susan Hopkins being the chief medic at UXA, so I will have spoken to them about it, I'm sure.
You mentioned yellow card. Did anything during your term change at your direction in terms of how that system worked?
It wouldn't have changed precisely at my direction because this is a deep statistical and operational question. My job was to assure myself that everything was being done to make sure that the results were as accurate as possible rather than to design the system myself. But I know that both JVT and Susan Hopkins had a huge amount of experience in designing these sorts of systems.
Thank you. Thank you, Milady. Those are my questions.
Thank you very much, Ms Morris. That completes the questions we have for you for this module, Mr Hancock. I can almost guarantee, I think, that we'll be asking you to help us again. But thank you very much for your help this morning, and you're now free to go.
Thank you.
I shall return at 2:10.
All rise.